Hey, it's Dr. Kenneth Qiu. I'm here with Dr. Sterling Ransone, president of the American Academy of Family Physicians. We are sitting down here. It's actually day 2 of the DPC Summit, and we're going to talk about the future of primary care. So thank you for being here, Dr. Ransone.
Oh, it's my pleasure. Glad to be here.
Yeah, so you are the president of the National Organization for Family Physicians. So you kind of have your finger on the pulse of what's kind of going on in primary care right now.
I hope so.
As much as you can, right?
Yeah, exactly.
What are some, I guess, trends that you see going around nationally in terms of, I guess, primary care just in general? We'll leave it kind of open.
Well, I think the future of primary care is bright. The problem, and I'll start with problem. I shouldn't start there. I think that the pandemic really has opened the eyes of our country to a lot of the deficiencies that we have in our healthcare system. I think that in the United States, we have a fantastic sick care system. And that's part of the problem, is that we put our resources towards the care of sick, and we don't put our resources towards primary care. And as we, over the next few years, lobby and advocate for change at the federal level, we really need to increase the percentage of the spend of Medicare to have a higher percentage of primary care. I mean, I'd love to see it get up to 12% or so. And right now we're under 10. And when we can get that spend up, it will allow the Medicare reimbursement to physicians, to primary care physicians, to increase, so we can do what our patients need. And I think that we're starting to see the patients realize that this is where we need to put our investment in preventing disease and helping our patients prior to them getting sick. I think that when the pandemic hit, they realized that the historic lack of pay for primary care physicians grossly impeded the response to the pandemic. And we just need to fix that before the next one comes, which is, we know it's going to come sooner or later.
Yeah.
And we just need to work on it. But I'm really high on the way things are going for primary care right now. There are roadblocks and things that were or road bumps rather, that I think we're going to have to deal with. This year, probably the 2 biggest roadblocks we have are with Medicare. Actually, Medicare, the bump in funding through Medicare that we got for the pandemic will go away at the end of the year. And because of budget neutrality and the way Medicare has decided to change their spend on certain other things like nursing homes and hospitals and a few other things, primary care physicians could get up to another 1.5% decrease in payment from Medicare. And that's going to be about a 4.5% decrease. And with the inflation that we have now, with that on top of it, I think that we're going to spend a lot of our bandwidth over the next few months really trying to keep that from happening. But I think in the end that most of the folks in the legislature and most of the patients realize that in order for our populace to get the best care, they need to better incentivize and better pay primary care.
Yeah, that's right. So okay, payment that definitely comes. It's
one of the many things. And I guess you lead with payment because a lot of times that's what we end up having to talk about, because everyone always wants to nick away at payment. But I think when you look at outcomes, a couple of great studies have come out that showed that if there's a primary care provider in your community, the community lives longer. If they have a specialist in their community, or a partialist, as some of us like to say, in your community, they live a little bit longer, but nowhere near as long as if you've got a primary care doctor. Some of the studies since the vaccine has come out during the pandemic have shown that if you've got primary care providers in your community, the top decile of folks with primary care providers have a over 5% greater vaccination rate than the lowest decile. So if you've got primary care physicians, you live longer and do better in the long run. So I mean, I think just kind of showing the data to a lot of people will help get that movement going that we need to support primary care practices in the U.S.
Yeah. So you actually touched on a couple of things. You talked about payment, and then you talked about value, and that's a good segue into value-based care, the newest buzzword in the healthcare sector. What do you think about value-based care, the different flavors of it? Because, I think everything from ACOs to Medicare Advantage to direct primary care all falls under this umbrella of value-based care. So what is your kind of definition of what value-based care is, and how do you see these things moving the needle in terms of payment?
So, when you look at value-based care, the idea of value-based care is something that I think all of us could get behind, is that in the end, we want to pay for quality of care and how the patients do as far as outcomes are concerned versus the current model where it's all E&M coding, but that's all churn and burn. It's getting patients through its volume of care, not quality and outcomes of care. And part of the value-based care movement is trying to look at outcomes and say, we need to look at that, and that's what we need to reimburse. So, with a lot of prospective payments, when you can put that money forward so that the primary care physicians can invest in a robust architecture in their practice, they can get ahead of the game, and you don't have to bring every hypertension patient into the office just for a 6-month follow-up so they can get their medication.
Mm-hmm.
You can spend that time doing other things to keep people healthy. But again, the way we're paid now is they have to come in the office for you in order to generate a bill that you can get paid for your services. So, a lot of the prospective payments, I think, are one of the ways that we really can help with this. The problem is that the incredible complexity of a lot of managed care of ACOs and things like that, it disincentivizes the smaller, more rural, more folks who are in underserved areas from taking advantage of a lot of those programs, because they just don't have the time and they don't have the staff to check all the boxes and to do all of the requirements that are currently required under certain contracts. So, I think whatever we can do to, if you've got 4 different insurers, they're all trying to do value-based care, but all of them have different metrics.
Mm-hmm.
How are you going to do all that for all 4 of them? If we could align a lot of the metrics, if we could make them simpler, if we can make them actually something that's applicable to long-term patient health, I think people wouldn't mind doing that. But when everyone's different, you're not sure that over, half of them actually benefit your patients. A lot of folks just say, well, I don't have time to do that. And they don't take advantage of potential resources that are out there.
Yeah, for sure. Another thing that's kind of developed, since the internet, I guess, is technology, right? Technology is kind of taken off, and one thing in healthcare is that we're really behind, right? I graduated residency last year. I still use the pager. What do you see any technology coming into the primary care space to help either with patient care, with reimbursement, or what are some kind of tech solutions you've seen recently?
It's really interesting. So I'm in the generation of folks who somewhat feel burned by the electronic health record.
Right.
When they came out, we were promised that we could see more patients more efficiently, and it was going to make things easier. And what it turned out to be is just a box clicking exercise.
Right.
And so folks in my generation are really, a lot of them are down on technology just because of their, the bad taste in their mouth that's been left over because they didn't get what they thought they were going to get with a lot of electronic health records. A good friend of mine, Reed Blackwelder, is a former president of the AAFP. He calls it electronic billing record, or EBR, instead of EHR, because that's what they're really good at. They're really good at billing, but they're not really as good at patient care or assisting us in our patient care. But where things are going, there are a lot of things out there that I think can bring services into my practice. I'm in a rural area. I'll give you an example. So let's say I've got a diabetic patient who they need to get their yearly retinal exam because we're trying to make sure they don't have diabetic retinopathy. And they have to take a day off of work to drive over an hour to get to the closest retinologist, it's time away from their work, it's expense, and now there are technologies out there where you can take a photograph of the retina in a primary care office, plug the data into an artificial intelligence, and they can diagnose diabetic retinopathy as well as a fellowship trained retinologist. So getting that type of technology into primary care offices will be good for our patients because, again, during our normal diabetic follow-up, we can do those kind of exams. They don't have to take more time off of work. They probably be more likely to come in and get the care that they need because they don't need to take as much time off of work. And we can end up, in this case, saving people's vision. Now, what the challenge is going to be is showing the value proposition of that so that we can be paid so that we can get that type of technology in the office. And that's where the big challenge is. But there, a lot of the AI and machine learning technologies are emerging out there to help us take better care of our practices. And I think probably the next big one is going to be self-documenting records and things like that. So a lot of the nitty gritty that we have to do in our office, if that can be automated, I think that will help a lot with burnout. And I think it will help a lot with us. It will help us take better care of our patients. There was one of the, I was talking with another AAFP president from a few years ago who went to a tech conference with Google. And Google has this box. It's probably about the size of this table that we're at. But
it's a big table, by the way.
It's a big table, but it's got cameras, it's got voice recognition in it. So the early technology was when you walked into the room, the patient's chart was already up because it recognized the patient. When the doctor walks in, the recognition technology recommends who the physician is who walked into their room. And the technology was good enough that if the physician walked to the patient, examined their right elbow, it knew what you were doing. It would document it in the patient record, and all you have to say is what the pertinent positive findings are, and it goes right into the record.
And it was cameras watching you.
Yeah,
as you did.
In the room as you're watching.
Oh, wow.
Now, yeah, and
when was this?
About 3 years ago.
Oh.
So again, as we go, what's the law? Every 18 months, the technology doubles.
Oh, gosh.
As time goes on, think where we can be, where we won't have to pay a scribe, or we won't have to spend 3-4 hours after clinic time just trying to get the charts where they need to be. And if we can just say, this is the pertinent positive finding, the patient, you give them where they're tender, you say the patient has tendinous elbow, this is what we're going to do for treatment, and the AI hears that, sends the prescription on. All you have to do is say it. That's going to be a huge time saver, but it'll give us more time to spend with the patient doing the other things that the patients want, which is FaceTime with their physician. I mean, for me, if I'm at a laptop and my head's down like that, no one wants to see this. I mean, they want to look you in the eye. And I think that automating the boring, repetitive stuff that we have to do. I mean, we are really, really well-paid transcriptionists, and we need to get that part of our practices gone so that we can actually do what we're trained to do, which is diagnose, treat, and care for our patients.
So one of the issues right now with at least the traditional fee-for-service is that, doctors have to see a ton of patients, right? And then they get hit with all the admin. Well, what is to kind of stop these larger employers from just increasing the number of patients once the admin work is reduced?
Yeah, that's a great question. And, I think it part of it is on the physician, part of it's on the patients to say what they want, and again, we're at the DPC summit. And so, I think that a lot of, the attraction of doing direct primary care and getting out of some of the hamster wheel of the insurance companies is the ability to have smaller patient panels so that you can spend more time with each patient when they're in the office. And I think that's a huge attraction for a lot of physicians and for a lot of patients.
Yeah. So, I mean, it kind of sounds like, with technology, there's also we should also look at these payment models and see how new technologies can pair with these innovative payment models, and maybe even kind of remake primary care. Yeah, I think maybe it's time for a bit of an overhaul.
Well, I think we can't demonize technology. Nothing is ever going to replace one's trusted family physician. And, I think that there's a certain anxiety about technology for a lot of things. You look at, automobile building robots or replacing people who did it. That's never going to happen in primary care, despite the, the holographic physician on Star Trek. I mean, the patients want one-to-one time with their trusted physician because they trust us. A lot of them, will read things online. They'll go on Google, they'll go on Facebook of all things to try to get information, but they still trust what we have to say. And we need to have the time to counsel them appropriately so that they make wise healthcare choices.
Right. On that note, though, what do you think about like these direct-to-consumer companies that are like, for example, Roman started with erectile dysfunction. The parent company Roe now valued at $7 billion. So kind of healthcare as a consumer service. Do you see that shaking up primary care as, because primary care can be defined as the point of first contact for someone's healthcare, and if it's these direct-to-consumer things, I guess how is direct-to-consumer shaking up primary care, if at all, in the long run?
Well, I think that anytime there's innovative technology, people get concerned about it. When the first cell phone came out, I mean, what more disruptive technology can you have than a cell phone?
Right.
And I can remember people going, cell phone, what do you need to carry your phone around with you for, right? And now what do we use it? We use them for everything. I think some of these more disruptive technologies, a lot of that will shake out in the end, because I think a lot of people will when they use those type of services, frequently they'll end up back in our offices asking what we think of it. And I've had that happen before. Well, I did this and I'm just not sure if I should take the medicine they mailed me. And so then I'll have time to sit down and talk with them about those kind of things, So I think that every time you look at this, you want to make sure that your patients get the best care possible. And you want to be an available resource for them if they make unwise decisions and they have an issue. I think that a lot of the direct-to-consumer things I have issues with, because a lot of patients don't know their own risk factor. How many of us have, a lot of them don't know the medicines that they're taking to begin with. How many times have you said, what do you take? Well, I take this little white pill.
Right.
Oh, which one? I don't know what it's called, doc. And it's like, and that was one of the, the benefits we were hoping with a lot of the electronic health records is that I could get, the ER doc that saw you last night and gave you a little white pill, I could find out what it was and the patient wouldn't have to remember it. But then we have interoperability standards that were never generated, so their computer can't talk to ours and you get an issue. So, the sharing of knowledge, I think is where a lot of medicine is going to go, and who better to help our patients with their health knowledge and folks that they already trust, through their family doctors.
Mm-hmm. Yeah. And then, technology, especially nowadays, since it's progressing so fast, do you see a change in attitude in generations between doctors like myself who are just coming out and then doctors who are, closer to the retirement, burned by EMRs?
Yeah, well, I think so, because I think generationally, there's more trust and facility and use of technology with the younger generation than it is in mine. For us, the joke for my parents' generation was, ask my age, how do you work the VCR? VCRs aren't even around anymore. So what do we do now? When I have trouble, with something on my phone, I'm like, I'll ask one of my kids, what do I have to do to get this so it stops screaming at me, or whatever it might be. And I think that that the generation that has kind of grown up with handheld technology will find more uses and more beneficial uses for it in the healthcare sphere. I think that for me, I do a moderate amount of telemedicine, and knowing how to use those things really has helped me take care of a lot of my patients. Telemedicine is absolutely fantastic for behavioral health care. Probably most of my telemedicine visits are in the behavioral healthcare space. And it's great when you've got somebody you've been seeing their whole life, they've gone off to college, and you can keep up that trusted relationship with them off at college, if you're seeing them for their ADD or whatever it might be. I've had a lot of my follow-up visits, folks who have their iPhone, that's a trade name, I shouldn't say it, but they have their cellular
Yeah,
phone
sure.
that we can have that visit, that they will get up from their desk at work. I've had telemedicine visits in a bathroom stall with the patient.
Wow.
I was not in the bathroom stall, they were.
Yeah.
And, I've had folks who go out to their car.
Mhm.
But again, what that technology has allowed them is to get good health care without disrupting their daily life as much. They go back to work and after our visit, and they haven't had to take a half day off work. And it's been good for them. It's been good for their employer. And they've gotten good medical care, and and that type of technology has allowed me to reach the patient where they live. I mean, I've told folks many times, telemedicine to me it's the house call of the 21st century. I can go and you can assess social situations for a lot of my patients who are disabled, who have a lot of difficulty getting out of the home to come to our office. I can visit them in their home. Telemedicine is a tool. It's a tool just like my stethoscope or my reflex hammer, and being able to use it appropriately in a manner in which I think is appropriate and in a manner which the patient wants to use it. I think it's all going to be good. The concern is that some people don't see it as a tool in helping us in our medical home. They see it as an end in and of itself, and it's not. It's just it's a tool that will help me take better care of the patients. And frequently I'll see folks and say, I think you need to come into the office, and we'll bring them on down and we'll do what we need to do. But it's just another touch point that'll allow me to take better care of my patients.
That's right. And so what's interesting is there's this huge sector called health tech, right?
Yeah.
A lot of professional widget builders, sometimes, building a widget looking for a solution. How, speaking to that crowd, like how would you say is the best way to engage with primary care physicians, with family physicians, and potentially even the academy?
Yeah, I think you need to start you need to start with the physician perspective of these things. It's if you build it, will they come? Well, a lot of times there's something you can do, but there's really not a market for it, or it's not something that that would be useful. I mean, it might sound really cool, but do you really want to invest a lot of time and resources and a lot of money to develop, fully a product that that we might already, have an answer for? And I think you need to, the problem that we're getting, and the problem with a lot of the electronic health records, again, or billing records, if you wish to call it that, that when they were developed, a lot of them, and since they've been kind of advanced, they're great at what they do, which is aid in billing, but they're not great in helping take care of patients. And if you involve the primary care physician perspective from the get-go, I think you will end up with a technology sphere that's more user-friendly, more physician-friendly, and will actually help us take better care of our patients.
Yeah, for sure. Very cool. So nice, cool look into primary care technology and some trends, payments, and all that. A lot going on. And
there's a lot going on.
Yeah, primary care is kind of a hot space right now.
I think so. Oh,
yeah.
Absolutely. Yeah. And it's really interesting when we go and lobby. We're respected and listened to because we're primary care physicians, because we're family physicians, and they know that we have the best interests of our patients at heart. And it's really been fulfilling to be able to help us all take better care of our patients.
So, yeah. And that's the goal, right?
Oh, absolutely.
That's what we do.
Yeah.
Awesome. Well, thanks so much for being here, for sitting with me and answering these questions.
That's great.
Yeah. All righty.
Take care.